Hello, everyone. Welcome to our session on navigating the Inflation Reduction Act, insights from Reg Waldeck on the future of U.S. healthcare. I'm Noa Vaamonde Torres, and I specialize in healthcare business development and consultancy at Succelerate. As part of our ongoing Succelerate Talks series, where we engage with key players in the healthcare industry, I'm thrilled to introduce today's distinguished guest, Reg Waldeck, with over 25 years of experience in the US, Australia, and global healthcare markets. Reg is an expert on the evolving US healthcare system and the profound implications of the Inflation Reduction Act. Before we dive into our discussion, let me take a moment to introduce Accelerate, provide some background on today's topic, and introduce our esteemed guest, Reg Waldeck. Succelerate is a Swiss-based life science and healthcare consulting partner committed to supporting innovation in the healthcare sector. Our mission is to provide customized and personalized strategic services to our partners, leveraging decades of experience across pharmaceuticals, biotech, medtech, and consulting. Our expertise spans strategic commercialization, clinical and medical affairs, market access, and reimbursement. The topic that brings us together today is the Inflation Reduction Act. This significant legislation addresses various aspects of the U.S. economy and carries profound implications for the healthcare sector. In the United States, healthcare is a complex system involving multiple stakeholders, including private insurance, companies, governments, programs like Medicare and Medicaid, healthcare providers, and patients. And without further delay, I'm delighted to introduce Reg Waldeck, who will help clarify the implications of this new act for the U.S. healthcare sector. Reg is currently the head of global market access at Bayer. Reg, could you please begin by sharing a bit about your background and your experience within the Inflation Reduction Act in the U.S.?
I'd be happy to. As a disclaimer, the opinions expressed are my own and not those of my employer. That said, to start, it's worth mentioning that the IRA has evolved out of previously evolving healthcare legislation, notably the Medicare Modernization Act and more recently the Affordable Care Act. It's probably also fair to say that some of the ideas around the provisions in the Act took a page out of how other healthcare systems around the world operate and the kind of mechanisms that they have adopted over the years in managing their respective healthcare budgets. In the end, healthcare legislation and policy provide incentives and in some ways a set of rules that shape the balance between managing healthcare investment, innovations, and costs. And perhaps part of the value of my perspective is one that encompasses various healthcare systems around the world, which then allows you to compare approaches and gain greater insight into which types of policies tend to promote which effects. And having lived on 3 continents and experienced healthcare myself in the US, Europe, and Australia, I can add some real-world experience which can round out the professional perspective.
Wow, thank you, Reg. Your background and experience across these areas assures me that today's conversation will be highly beneficial for our audience. So let's start with our first question. So, the Inflation Reduction Act is a significant piece of legislation that allows Medicare to negotiate drug price directly. This shift is expected to have potentially wide-ranging effects on the healthcare industry, related to drug prices, insurance premiums, and out-of-pocket costs for patients. Reg, how do you see the IRA affecting the broader healthcare industry in the US?
Yeah, it's worth reminding ourselves that the IRA aims to introduce pricing reforms through direct negotiation, a departure from the original Medicare statute of providing reasonable and necessary care. It fundamentally includes 3 provisions. The first is to extend the so-called healthcare CPI or Consumer Price Index penalty to extend beyond Medicaid and now include Medicare as well. Second, there is the introduction of direct price negotiation by Medicare Part D, the benefit for self-administered products such as pills and self-injectable subcutaneous injections in 2026, and Medicare Part B, the benefit for physician-administered drugs, which will go into effect in 2028. These negotiations will result in a so-called maximum fair price, or MFP. The impact of this negotiation is playing out as we speak for the first 10 directly negotiated drugs, which were selected based on their financial impact to CMS. The third provision is the Medicare Part D redesign. One of the main aspects of the Part D redesign, which now allows Medicare to negotiate drug prices directly with pharmaceutical companies, is that it meaningfully changes the relative, parts of the costs covered by each of the government, payers, and manufacturers. The redesign removes the so-called donut hole in which patients could have considerable copays, as well as no more patient contribution in the so-called catastrophic phase, which for higher cost drugs introduced further copay liability for patients. These costs are to be made up by greater payer and manufacturer responsibility to cover these costs. So the first impact of these changes is now starting to play out, as this greater cost share by payers could lead to higher premiums, which indeed appears to be the case, with the government now subsidizing Medicare Advantage plans by approximately $5 billion, offsetting the majority of purported savings communicated by the administration of about $6 billion by 2026. Because of the recency of these events, we need to be careful not to extrapolate too much, but it is very important to delve deeper than surface level on these matters and rely on quantitative analysis, which many in the field have started to do since last week's MFP announcements. In addition, the Part D redesign will cap the patient annual maximum out-of-pocket payment to $2,000 and is currently addressing mechanisms of smoothing out-of-pocket expenses for patients over the course of a year. This provision may be anticipated to have a beneficial effect on a problem called pharmacy abandonment, which oral oncologics, for instance, has proven to be substantial, with some 1/3 of patients abandoning the script at the pharmacy when their copay outlay is between $100 and $500. Thus, with a combination of capping the annual out-of-pocket cost for a patient to $2,000, as well as helping patients smooth such payments over the year, rather than having to deal with a high out-of-pocket payment early on in the year, the out-of-pocket patient maximum payment is reached. Notably, the provisions will and already have had implications for drug development, with development of pills that will be subject to the 9-year period without direct negotiation in Medicare Part D. Some of these development programs have been stopped to date, and conversely, now companies may be focusing on IV-administered drugs or biologics that extend this period to 13 years. This perhaps unintended consequence is now more widely recognized and perhaps will be addressed in future amendments. Medicare and Medicaid are two critical programs in the US healthcare system. While Medicare provides healthcare to seniors, Medicaid assists low-income individuals and families. The IRA includes provisions aimed at reducing costs for these programs, which could lead to substantial changes in how they operate and how beneficiaries access and pay for their healthcare.
And what specific impact do you anticipate for Medicare in terms of impact on patient out-of-pocket payments costs?
Yeah. Broadly speaking, today in the US, patients either pay a fixed copay, typically in the range of $100 to $300 for most primary care or, let's say, non-specialty drugs. For specialty drugs, these payments can take on a percentage of the list price or wholesale acquisition cost, what we call the WAC. The average percentage of such coinsurance for specialty drugs for employer-sponsored healthcare is of the order of 26%. Thus, for commercial patients, having a reduced list price would indeed lead to a lower out-of-pocket payment. But for many Medicare enrollees, copays are of the fixed type, and those enrollees would not see a reduction in their out-of-pocket layout as a result of the IRA.
In your opinion, Reg, how do you foresee private insurers responding to the IRA? Could they offer improved benefits designs and formularies for their enrollees as a result?
Now, this will be one to watch over time, but perhaps we should start with a quote by an economist called Thomas Sowell, who said there are no solutions, only trade-offs. It is not straightforward to try to project what may happen over the longer term, as especially in the commercial setting, the impacts may be more indirect and also subject to other reforms, notably PBM reform, possibly evolution in approaches to copay maximizers and accumulators, etc. How commercial insurance that administer the Medicare benefit as opposed to fee-for-service or FFS Medicare will react is also likely related to the changes in rebate structure and payments that will be affected significantly come 2026. If for now we stick to some of the more recent reports that have come out relating more directly to Medicare prescription drug plans or PDPs, which provide only the Part D benefit, and the so-called MA PDPs or Medicare Advantage prescription drug plans, administering both the Part D and C, the medical care benefits. A couple of trends have been highlighted in the recent public domain. First, some recent actuarial calculations done by Milliman et al., as commissioned by the Pharmaceutical Research and Manufacturers Association of America, or PhRMA, indicates that Part D premiums by 2026 will go up on average 12%. For the low-income subsidy part of Medicare Part D, that increase is estimated 26% increase. So before we speak about how prescription drug plans and Medicare Advantage prescription drug plans may offer comprehensive benefit designs, I think we will need to see how the story on premiums play out. There's in fact a premium stabilization provision in the IRA that intends to cap premium growth, anticipated as a result of the greater cost share taken on by payers administering the Part D benefit to 6%. And I think we need to wait how this plays out to make any predictions on how benefit designs may change. But one trend that has already been mentioned in the public domain is a shift from PDPs to Medicare Advantage PDPs, as the latter are better equipped to spread the risk of the added cost share across additional services. And the vast majority of Medicare Advantage prescription drug plans enrollees, which today constitutes about 55% of Medicare enrollees, pay a $0 premium. And so this dynamic is another potential trade-off of the Part D redesign, which is yet to play out.